So,
Shall we start, ma'am? Then,
yeah, please, we can start. No,
yeah, yes.
usually, Dr. Bhave, without fail, he joins, but maybe he's
He
busy
might,
some.
yeah, or he might join later on.
Mm, yeah, yeah,
So, okay, we can start, I guess, then.
yeah, sure, please.
Yes. Good evening, everyone. It's a beautiful Friday evening, and it's an exciting feeling to meet all of you on this Zoom platform for today's academic session. I'm Dr. Ila Vatsala Sharma, consultant psychiatrist at Vadodara. It's my privilege and honor to serve as a moderator for today's session. And on behalf of Women Child Mental Health Committee of Psychiatric Society West Zone, although sir is not here, but I would like to welcome all the president, Dr. Sudhir Bhave sir, and all other office bearers. But our chairperson is here, Dr. Ritambra Mehta ma'am, and all other office bearers. I would like to welcome a warm welcome to all of you. So uh, today's session is on managing women sexual dysfunction, what every clinician must know. This topic is usually ignored in our daily practice. So today we'll have our invited our speaker, Dr. Veda Shetagiri ma'am, for reflecting more on this topic. Ma'am is professor and head of department, Point College of Medical Sciences and Research Center, Bangalore. She has done MBBS and MD in psychiatry from Jawaharlal Nehru Medical College, Belgaum, and fellowship in psychosexual medicine from JSS University, Mysore. Ma'am has more than 15 years of experience in the field of psychiatry. She has various publications in national and international journals. She is convener IPS PG Academic Subcommittee and in IPS South Zone Women Empowerment Committee. She is co-chairperson of IAPP Women Mental Health Specialty Session. She is EC member of IAPP Karnataka State Branch. She is contributing author for the books MCQs in Psychiatry and a chapter on PTSD in the book titled Gender Trauma by IPS South Zone. She is editor of Manodarshika Calendar in Kannada language for IPS Calendar Task Force. She is assistant editor of IJPM and reviewer of Journal of Psychiatry Spectrum and Journal of Psychosexual Medicine. So a very warm welcome to our respected speaker, ma'am. So this session will be for 1 hour, and ma'am, you will have 45 minutes and for conducting and delivering the talk, and thereafter we'll take question and answers. So I request all the audience to put questions in the chat box, and we'll take them once the session is over. So I
Before
guess
she
now it's
starts, let me also just welcome Dr. Veda.
thank
Uh,
you.
sh- uh, she has actually been very active, as she said, in the women's mental health field, and she also has this fellowship on in sexual medicine. And I hope that, and I see her these flyers that she keeps talking on these areas of sexual medicine, especially women, in many conferences and CMEs. I have shared the seat of examiner with her once, and I know that she is an excellent examiner and a mental health expert. Welcome, Dr. Veda.
Thank you so much, Madam and Dr. Ila, for your kind introduction. So, without wasting much of our time, I think we will hit on the topic now. That is what every clinician should know about female sexual dysfunction. So, I feel every clinician, whether it is a psychologist, whether it is a psychiatrist, gynecologist, a general physician, or any endocrinologist, we all should be very well versed in this, topic of female sexual dysfunction, because it is one thing which is highly prevalent in the society. Let me make a note that female sexual dysfunction is more prevalent than male sexual dysfunction. Although there lies a taboo, there is a stigma, with all the available data still reports that female sexual dysfunction is more than males. And because of the cultural sanctity, or because of the patriarchal societal concerns, most of the times the women feel quite embarrassed and they really don't open up to us. So though it is highly prevalent, it is underdiagnosed and a multidimensional condition, it definitely plays a very significant role in contributing to overall quality of women's life, and it affects the relationships and causes even mental health disturbances. So this topic is quite pertinent for the current generation also. I'm told that even postgraduate students are likely to join this webinar as well. So coming to the topic in particular, so there's a famous saying, men and women approach sex very differently. Men make love to feel love, whereas women need to feel love to make love. So I would be taking you through these headings. That is the magnitude. How much is the magnitude of the problem? How do we actually classify female sexual dysfunction? Detailed sexual history, how it needs to be obtained, the local as well as systemic examination, the onset and the context of presentation, various assessments for physical as well as psychological comorbidities, drugs related sexual dysfunction, if any, and what all are the general principles that one needs to follow in the management of female sexual dysfunction. There are various treatment approaches as well, as you all very well know, pharmacological as well as non-pharmacological. So what all are these hormonal as well as non-hormonal medical therapies available? So, sexuality definitely encompasses all the thoughts, behavior, feelings that is connected with the sexual gratification and reproduction, which includes even attraction of one person to another. So this is very much common even with humans as compared to animal species. It is not just about reproduction, but it is also about gratification and pleasure. So human sexuality is shaped not only by biology, but it also is contributed by social, cultural, interpersonal, as well as psychological constructs. Now, let's have some MCQs in the beginning and know as to what all do we know about female sexual dysfunction. Just a brain teaser for a while. So the first question is, prevalence of female sexual dysfunction can vary between dash across the world. So the options given are 50 to 70%, 30 to 43%, less than 20%, and more than 70%. Can I have some answers from all of you? Any responses?
Uh,
You can just post your answer in the chat box. I get an answer as B.
then A.
Yeah, one or two have responded as A. Okay. So the answer here is B. It is anywhere around 29 to 42.7%. So antipsychotics affect which phase of the sexual response cycle? Can we have some responses, please?
B.
In which phase of sexual cycle, response cycle, does antipsychotics affect? Is it the libido? Is it the desire? It is desire and orgasm related disorders. The correct answer. The factors contributing to a woman's inability to achieve orgasm may include all except past traumatic sexual experiences, primary ovarian insufficiency, fear or insufficient knowledge about sexual experiences, or patients on GnRH analogs, OC pills, and danazol. What do you think is the right answer? Any guesses? So the correct answer is the patients on GnRH analogs, OC pills, and danazol. Now, the next question is implicit model is an approach consisting of all except permission, limited information, sexual stimulation, and intensive treatment. Can I see some of the responses, please? Yes, Madam has answered it right. It is C. It is specific suggestions and not sexual stimulation. Flibanserin is a drug with the following action except 5-HT1A agonist, 5-HT2B agonist, dopamine D4 receptor moderate agonist, and 5-HT2A agonist. Any answers? Any guesses? It is 5-HT2A antagonist and not agonist. That is D. In a neuroimaging study, which brain region is consistently shown to be hypoactive in women? Prefrontal cortex, amygdala, anterior cingulate cortex, and nucleus accumbens. Any guesses? So the answer is nucleus accumbens. So before we begin with the sexual dysfunctions in particular, I would like to just highlight these four models that were described by Master and Johnson's in the year 1970. Here it included excitation phase, the plateau phase, orgasm, as well as the resolution phase. In the next model that followed, it was by Kaplan in 1979, wherein they gave more importance to desire and libido even much before excitation phase. The third model which followed was Whipple and Brash McGear model, which was a linear model which said that seduction, sensation, surrender, and reflection are the four stages, wherein just the names differed, but it also referred to the same, unlike the DEOR model. Like for example, seduction here referred to desire as well as attraction. Excitation phase went in concurrence with the sensations, that is excitation as well as plateau, orgasm with surrender, and reflection as a resolution. The last model that came into existence was the biopsychosocial model, which is the circular model. This is basically for long-standing relationships. Here it says that each time before having sex, there need not be a desire component which needs to be always there. Even a sexual stimulus can result into some amount of arousal in between two partners, which can result into sexual desire and then can result into sexual satisfaction. Here in this model, which is the latest and the most accepted model, they have given more precedence to intimacy needs of an individual over other needs. Coming to the female sexual response cycle, I have just put this graph to highlight the fact that a woman can have multiple orgasms and she always reaches a resolution phase, unlike men who do not reach this refractory phase. Now, coming to the magnitude of female sexual dysfunction, as we all know that in the year 2020, there was a global survey that was conducted across 30,000 women in 20 countries. Here, they reported anywhere sexual dysfunction between 15% to 50% with respect to various domains. It could be the desire, arousal, or orgasm and pain-related disorders. There was one more survey which came from United States where they also concluded saying that around 43% of the women reported a sexual problem with her personal distress. Indian data for the last 5 years estimates a range from 36% to 50% of female sexual dysfunction, and the commonly reported domain of the sexual dysfunction here was low desire or low libido, which was seen in around 52% of the cases. In most of these studies that they have done across the world, the most commonly used scale there was FSFI scale, that is Female Sexual Function Index. There is a meta-analysis also wherein they have a pooled prevalence data of any female sexual dysfunction amounting around 41.2%. There was an impact of COVID-19 also. There's a nice study that was done by Italians in the year 2021, wherein they also concluded that around 47% of the women reported with sexual dysfunction. Now, coming to the topic in particular, that is the classification of female sexual dysfunction. As you see here, there are desire difficulties, orgasm related difficulties, genitopelvic pain disorders, and excitement or arousal difficulties. Now, we have multiple types of classification for the same, but I will be just discussing in brief about DSM 4, 5, and ICD 10. So, there is a comparison slide wherein they have compared between ICD-10, DSM-5, and ICD-11. ICD-10, the most commonly followed. Here, sexual dysfunction is categorized under mental and behavioral syndromes, that is sexual dysfunction, non-organic cause, where subcategories are lack or loss of sexual desire, lack of genital response, orgasmic dysfunction, sexual aversion, vaginismus, or dyspareunia. In DSM-5, the classification remains as sexual dysfunctions. Here, we have female sexual interest or arousal disorder, female sexual interest or arousal disorder, female orgasmic dysfunction, and genitopelvic pain and penetration disorder. Under ICD-11, we have conditions that are related to sexual health. Here we call it as HSDD, that is hypoactive sexual desire dysfunction, female sexual arousal dysfunction, orgasmic dysfunction, and sexual aversion is no more an entity there. And the last one is so-called as sexual pain or penetration disorder. So these four we are going to discuss in detail. So briefly, I'll just highlight about the structures that are involved in neurobiology of female sexual dysfunction, as well as the neurotransmitters and the hormones that are involved. So as we all know, dopamine is a hormone which is very much essential for any for sexual desire or motivation. So it is a pro-sexual hormone neurotransmitter to begin any sexual activity. Serotonin, in contrast, is an anti-sexual neurotransmitter which plays definitely a role in arousal as well as inhibition. Oxytocin is very much needed for bonding and orgasm, which helps in facilitation of the orgasm. Then coming to norepinephrine, which is very well known to cause arousal as well as attention, very much needed for arousal as well as attention. And endogenous opioids, these are known to modulate the pleasure. Estrogen and testosterone, unlike any other hormones, very much vital for vaginal lubrication. So anatomical structures of the brain involved are hypothalamus. This basically requires integration of both the hormonal and the sexual cues. Amygdala for the emotional processing. Prefrontal cortex has a role to play in inhibition as well as control of the sexual impulses. Nucleus accumbens definitely the reward as well as motivation. Like I mentioned in one of the MCQs, the size of the nucleus accumbens is seen to be smaller in size on an fMRI in patients who are diagnosed with HSDD. Insula, that is body awareness as well as interoception. Coming to the first sexual dysfunction, that is female sexual interest or arousal disorder. Here, the patient presents with lack or significantly reduced or sexual either in terms of sexual interest or arousal. So it should be more than 3 in number, either in terms of absent or reduced interest in sexual activity, absent or reduced sexual or erotic thoughts or fantasies, or there should not be any interest to initiate a sexual activity itself, and typically unresponsive to a person's partner's attempts to initiate. There should be reduced sexual excitement or pleasure during sexual activity in most of the sexual encounters, or reduced sexual interest or arousal. May it be to any kind of cues, it could be written, verbal, or visual. and genital or absent or reduced genital or non-genital sensations. So out of these six, more than three have to be present, and this should be present for a duration of approximately at least 6 months, and it should cause significant distress to the individual at any given point in time. And this should not be explained by any other non-sexual mental disorder, that it could be secondary to relationship distress or partner violence or any other significant stressors or underlying general medical condition or induced by a substance. Now, the specifiers across these disorders remain the same. So, it could be either lifelong, generalized, or acquired and situational. Severity wise, it is classified under three headings, that is mild, moderate, as well as severe. Then coming to female orgasmic disorder, here either of the following symptoms are experienced on almost all occasions of sexual activity. That is, either there is a delay or relatively less infrequent or absence of orgasm, or markedly reduced intensity of orgasmic sensations. And it should be present at least for a period of about 6 months, and this should again cause clinically significant distress. Genitopelvic pain or penetration disorder. This is with persistent or recurrent difficulties with more than or equal to one of the following. That is, there should be difficulty in vaginal penetration during intercourse. They should have marked vulvovaginal or pelvic pain during the vaginal intercourse or penetration attempts. Then marked fear or anxiety about vulvovaginal or pelvic pain in anticipating of any time vaginal penetration, and marked tensing or tightening of the pelvic floor muscles during attempted vaginal penetration. So this again should last for at least for a period of about 6 months. Now, there are certain myths that are prevalent in the society. Like, for example, masturbation is only for males. A female cannot masturbate. A woman should not initiate sex. It is always the male partner who should take the lead. A woman should always have sex when her partner makes sexual approaches. Sex equals intercourse. Sex happens automatically. A respectable woman should not enjoy sex too much and should certainly not masturbate. Drugs increase the sexual potency and tubectomy decreases the sexual potency. And there must be something wrong with the relationship if the sex is not good. So these are few of the myths about sex among females. Now, there are certain general principles in the evaluation of any female sexual dysfunction. So, first is we need to assess the predisposing, the precipitating, as well as the maintaining factors that have actually contributed to sexual dysfunction. It could be primary or it could be secondary. What I mean by primary is the etiology largely remains the manifestation of the sexual dysfunction is the manifestation with which the patient comes to you. It is not the underlying mental illness that has contributed to the sexual problem. So, if there is a presence of sexual dysfunction secondary to any mental illness, then it would be categorized as secondary sexual dysfunction, and the underlying cause, it could be depression, it could be schizophrenia, it could be delusional disorder, or any kind of psychiatric illnesses. Those need to be treated first, much before this sexual dysfunction. The second thing is evaluation of a sexual relationship with partner. So, how good is the relationship of the person presenting to you with the partner? How often do they get along with each other? What are the, how good is their communication? How intimate are they? And what over a period of time, how the things have been between both the partners, and what brings the person to you to seek for help. So that those are few of the couple of the questions that you ask the patients and screen for the to know about their sexual relationship and how things have changed over a period of time. Then comprehensive medical and psychosexual history, assessment of sexual abuse, any underlying psychiatric illnesses, and then definitely if it is a lady who is presenting to you, a focused pelvic examination has to be done in case of any patient who has any kind of, a child history of sexual abuse, or she has come with a history of PTSD, or any violent behavior, any history that was given to the patient by the patient. So we should always see that we do a pelvic examination of the patient, and pap smear needs to be done in all cases of ST, because you need to even rule out all the local causes and medical underlying medical causes and surgical causes as well. And neoplasms are something which one has to always keep in mind. And even otherwise also with aging, when a lady has reached menopause, or she is in a perimenopausal phase, then the history taking with respect to these two things also becomes very, very, very important. Now, important aspects in evaluation: how one should be, and how do we actually go about assessing the sexual dysfunction. The thing is, one is, you should be empathetic towards the patients. You should have a non-judgmental attitude, and you should be very much understanding. You should be a silent listener. In first place, you should make the patient feel quite comfortable. See that you ensure the privacy and the confidentiality of the client as well, and you speak in a language which the client is comfortable with, and try to understand what is the client's knowledge while she walked up to you regarding about sexual functioning, etc., and try to explain her about sexual functioning, in case if she does not understand the anatomy or the physiology about the sexual act. Then coming to the you by yourself should never conclude saying that because maybe her IP relations are not good with the husband, the sex could be the only reason, or you should never conclude saying that perhaps she is bisexual or something like that. So never make assumptions in first place. So obtain sexual history from each individual separately. Even if they have come as a couple, see that you obtain the history from each individual separately. So then the culture and the religious factors which actually influence the sexual issues. That is, what type of a background that she comes from. Is it a very conservative type of a family where things are not outspoken? They have a lot of inhibitions, and it causes a lot of embarrassment for her to speak up about her sexual issues in front of a therapist. So all those things have to be kept in mind. And then reassure the client that female sexual dysfunctions are quite common, and these are all treatable conditions. Make her feel more comfortable that this is all this problem can be treated, and give her a reassurance from your end, and explain her in very simple, clear, and specific terms. And then there are several factors that are associated with sexual complaints. Like I said, underlying any physical illness, underlying any surgical or gynecological conditions, history of physical, sexual, or emotional abuse. In case of teenagers or adolescents, we come across with body image disturbances. Some of them do have certain preconceived beliefs and attitudes towards sex. So then history of substance abuse, and in current era, current generation, we have a lot of, we come across with work related stress. We are not able to give time to our spouse at times. So there is a lot of communication gap that actually happens between two partners. It is because of the hectic schedule. So all these things need to be asked from the patient. And are there any conflicts that are arising because of interpersonal issues? That temporal association also needs to be taken into account. Then, like I mentioned, I have listed few of the predisposing, precipitating, and maintaining factors. Let me just highlight few of them for you. So, predisposing factors are, see, like for example, restrictive upbringing right from childhood, disturbed family relationships, or traumatic early sexual experience, inadequate sexual information, or distractions. Precipitating factors could be partner dysfunction. Yeah, this is also quite common. Even though one partner has come to seek help, at times once when we interview the other partner, we get to know that both the partners have problems. It's not just the one person who has come with this problem, and both could also end up having the problems because one person ended up having sexual dysfunction that caused again distress, anxiety in the partner, and then he or she, whoever is going through any mood disturbances, most commonly depression, again that amounting to sexual dysfunction. So we should always keep the partner in mind. And definitely, if there is any discord in the marital relationships, if there is any following pregnancy or childbirth, otherwise also the drive for sexual performance decreases during that time, during lactation. So expectation of negative outcome, depression, underlying anxiety disorders, or performance anxiety. Maintaining factors are the most important, which is missing amidst most of the couple, is poor communication with each other. Loss of intimacy, loss of attraction between the partners over a period of time, impaired self-image. Then there is restricted foreplay, fear of intimacy, and depression or anxiety or any guilt feelings associated with sex. Now, how to obtain a simple sexual history, from a client who walks up to you? These are few of the questions that perhaps can help you out to screen the patient whether she is going through any crisis with respect to sexual dysfunction. Do you look forward to sex? Do you enjoy sexual activity? Do you fantasize about sex? Do you have sexual dreams? How easily are you sexually aroused or turned on? Or how strong is your sexual drive? There are a few questions that I have enlisted for those who want to specifically ask about orgasmic difficulty. That is, are orgasms absent and or very delayed and or markedly reduced in intensity? Is there any adequate and acceptable stimulation with the partner or with masturbation? Is the degree of trust and safety you feel you need is present or not? Is the fear of letting go of control bothering you? Or what do you fear may happen that could be negative? So, all these questions are basically based on these precipitating, predisposing, and maintaining factors itself. Now, now one who comes with the GPPPD, that is genitopelvic pain disorder, there you will ask these set of questions. Where does it exactly hurt? How would you describe your pain? And when does the pain occur? How long does the pain last? What all are your thoughts running in your mind while you are experiencing the pain? And does your body become, tense when you or your partner are trying to penetrate the penis? Now, how long does the pain last? Does touching also cause you pain or any other form of penetration hurt? Do you get hurt even when you wear tight clothes? So, do you feel subjectively excited when you attempt sexual intercourse? Does your vagina become sufficiently moist or you feel all the time dried up? Now, there are few medications. This is for postgraduates here. So there are few medications which we come across, in day-to-day life whenever we treat our female patients suffering from any psychiatric illness or any other medical illnesses. So most commonly psychotropic drugs, as we all know, first generation antipsychotics and even second generation antipsychotic drugs are very notoriously known to cause sexual dysfunction. Barbiturates, benzodiazepines, SSRIs, especially tricyclic antidepressants, MAO inhibitors, lithium, and phenytoin. To name few others, cardiac and antihypertensive drugs like lipid lowering medications, beta blockers, clonidine, digitalis, methyl dopa, spironolactone. Hormonal androgen antagonists, danazole, GnRH agonists and GnRH analogs, oral contraceptives, and tamoxifen, and others like aromatase inhibitors, chemotherapeutic agents, ketoconazole, phenytoin sodium. In case you have a patient on epilepsy, one should be very careful. Then coming to, there are some common medical causes of sexual dysfunction that you need to rule out. Keep in mind, metabolic syndrome being the first in the list, diabetes mellitus, dyslipidemia, obesity, hypertension, local causes, infections, thyroid and other endocrinal dysfunctions, spina bifida, spinal cord injuries, multiple sclerosis, CVAs, STDs are some of the few to be mentioned. Then psychiatric comorbidities, there is a long list of illnesses, all the anxiety spectrum diseases, disorders, the mood disorders, especially depression, Definitely, psychotic disorders, also schizophrenia, delusional disorder, personality disorders, substance-induced disorders are also very, very common. Now, there are few scales that I would like to highlight with respect to three domains of sexual functioning. That is, there are particularly scales that focus only on sexual desire. If you wish to do any study, then these are the list of scales that can be used. So, scales that are used for sexual desire are decreased sexual desire screener, most commonly used, and sexual desire inventory. These are to name a few. There are others like HISD and SADI. There are scales for orgasm as well. Orgasm rating scale, female orgasm scale, you can remember. Then coming to scales that are used for multiple aspects of sexual functioning, that is sexual functioning questionnaire. Then Arizona, most of you know this, Arizona Sexual Experience Scale. And we also have Female Sexual Function Index, that which was the one which I was mentioning, FSFI scale. That has got 6 domains, and the total score is anywhere around 56 or so. And then it is quite easy in any setup, it can be used. So, following after the assessment of sexual dysfunction using the scales, there are certain medical or physiological evaluations that one needs to do. That is, after detailed sexual history, don't forget to do general physical examination. Most of the times we do not do that. So, please see that general physical examination of the patient is done. And then, systemic examination, pelvic examination. Take the help of a gynecologist, definitely for the same. Hormonal profile, FSH, LH, prolactin, free testosterone, sex hormone binding globulin, and estradiol levels. Then complete blood count, lipid profile, thyroid function, ECG, RFT, LFT, and evaluation of the sexual response. Yes, you need higher investigations, then go for duplex Doppler ultrasound, vaginal pH, then measure the vaginal compliance or elasticity, and genital sensations by vibratory perception threshold. Then coming to yeah. This is very important slide wherein there are certain distinguishing factors which features that you need to know between organic sexual dysfunction versus psychogenic type of sexual dysfunction. The age of onset in organic, kindly remember, it is always older in onset most of the times. In psychogenic, it is quite in a younger age group. The onset is quite gradual in organic, whereas it is acute in psychogenic type. Circumstances wise, it is global, irrespective of whether it is even any partners. Right from the beginning, the person is going to have a difficulty that is global across all the domains of sexual life. This is very much situational. It could be because of underlying anxiety as well. Then, symptom course, it could be consistent or progressive, and in this here it is intermittent. Desire wise, it is normal to start with, but here in case of psychogenic, it is already reduced or decreased. Then partner problem is usually secondary there. Here it is usually at the onset itself. Then anxiety and fear, yes, here in case of organic, it is usually secondary, whereas in case of psychogenic, it is usually primary. So organic risk factors are definitely present, whereas that is most of the times absent or variable in case of psychogenic. Now, we need to assess, understand, and intervene. How do we do that? Now, after you evaluate, after you apply the scales and all, there are several few questions that you enlist and think over. Does this couple actually have sexual dysfunction? Does it really mean you have evaluated? Does it mean that the patient should be labeled to have sexual dysfunction? Because you need to rule out organicity, you need to rule out other causes also for sexual dysfunction. It could be a perimenopause or a menopausal lady as well, or a person who is just stepped into adolescence also has some kind of image related issues, body image related issues as well. So does this couple actually have sexual dysfunction is one thing that you will assess, whether it is primarily psychogenic or organic by nature. If it is organic in etiology, is there a secondary psychological overlay too? Once he has been diagnosed, has anxiety, has that also amounted to the existing sexual dysfunction? If there are anything more than one sexual dysfunction, then which came first? That becomes primary. So most of the times in female sexual dysfunctions, whenever they manifest, it is always an overlap of the three domains we usually see. distinctly, we hardly get to see patients who have exclusively female orgasmic disorder, or only libido or desire related disorders. Generally, there is always an overlap. And so, how severe is the sexual dysfunction? Is there any underlying psychiatric disorder? Is there a marital discord or a disharmony between the couple following this? And how well motivated are the couple to actually receive this treatment? And what is the level of psychological sophistication that they have? Now, what are the principles of treatment? One is you will inform the clients about all the available choices that you have, and you will guide them. So, you will discuss all the treatment options with them and inform both the pros and cons, and tell them this: you can select the treatment as per the client's choice. Here, you are not going to, lay your choice of treatment onto the clients. So, they are the people, you give the menu and they make a choice of what they like. So, and it is very much tailor made, okay? And it is nothing like, one size fits all. So, that has to be always kept in mind, and it is always case specific. So, what worked for your ex patient may not work for this patient. So, inform about the side effects, problems, and complaints, if any, and do not deny treatment in case the patient is unable to get his or her partner for treatment. At times, there are situations where unmarried lady also comes with a lot of problems, and then it is very difficult for her to express as to what she has gone through. In most of the times we see such, and when the partner is into substance abuse also, many a times they deny to come to the therapist. So there are difficulties which a woman might likely face, and manifest before the clinician. So, but we should never deny treating the individual who has come to us. Documentation becomes very, very important as to what is the initially what is the menu that was provided, what she has agreed upon, and what is the treatment plan that you have planned for. Then this is one of the very important models, even before we offer any kind of therapy. That is implicit model, very important model. P is nothing but permission. Here you discuss with the clients about what is their knowledge about sexual functioning, and you allow the client to actually talk with you. You are a silent listener. You allow them to give them the choice of to tell you about the sexual difficulties that she has been facing over time. Then limited information is something about about the anatomical the structures or the physiological aspects of sexual functioning related to actually sex or sexual positions. So here you can advise them about the books or bibliography and provide them limited information. Once they agree for a certain type of therapy, then you will suggest, yes, these are the different types of pharmacological and non-pharmacological treatments that are available. And if at all it requires any consultation liaison with other departments also, you need to get evaluated. And last is the intense therapy, wherein you give a combination of various therapies, whatever is available with you, like mindfulness technique, it could be cognitive behavior therapy, it could be dual sex therapy, set focus. So you try to explain them about the various non-pharmacological means of or modalities of treatment that is available. Next, coming to there are two types of treatments that we actually go for. One is the hormonal treatment of female sexual dysfunction. I will just run across the slide. And non-hormonal treatment of female sexual dysfunction. In hormonal treatment, as I told you, estrogen and progesterone plays quite a significant role in treating sexual dysfunctions. Estrogen, it will be in the form of conjugated equine estrogen, estradiol, estriol, or promestrine, and this usually is in the form of oral tablet around 0.6 milligrams per day, and estrogen transdermal patch is also available. So cyclic 3 weeks on and 1 week off, just to reduce the chances of endometrial hyperplasia. The second one is estrogen plus progesterone, wherein here cyclical estrogen and it is combined with progestin for at least a period of 10 to 14 days per month, because progestin will reduce the chances of endometrial hyperplasia. Then third is intravaginal estrogen. So that is in the form of either vaginal ring, tablets, or suppository or gel. Androgens like, in transdermal patch, testosterone is available, DHEA. STIR is a tibolone, and SER is again specific estrogen receptor modulator, that is ospemifene, that is around 60 milligrams per day. This is usually given for dyspareunia as well as vaginal dryness. This tibolone, ospemifene, and intravaginal DHEA. Then coming to non-hormonal treatment of FSD, we very well know FDA approved certain drugs are there. Those are like flibanserin. It is given around 100 milligrams single daily dose at bedtime. So it is very much approved in premenopausal women. Are not really very promising in case of postmenopausal women. Bremelanotide, again, it is melanocortin receptor synthetic agonist. So it is 1.75 milligrams subcutaneously given 45 minutes before on demand. And like I said, it is a MSH analog that can be used. And bupropion, again, 150 milligrams twice daily. This usually is used whenever we come across with antidepressant induced sexual dysfunction. We switch over the patient either to mirtazapine or bupropion, and trazodone 50 to 100 milligrams daily for SSRI related sexual dysfunction. Others like sildenafil, tadalafil, not really very promising, but can always be given as a trial. Phentermine, alprostadil, and Arginmax. Then coming to management of female sexual interest or arousal disorder, in particular, I'll just make a mention of few of the drugs that can be used. Flibanserin, like I said, it is FDA approved, 100 milligrams to be given bedtime. You give it for a period of at least three to 6 weeks and look for the response. Bremelanotide, again, it is given subcutaneously, 1.75 milligrams. It is 45 minutes before the sexual act. It has to be given. Hormonal therapy, transdermal testosterone therapy using 300 milligrams per day patch. Then estrogen can be supplemented in case of postmenopausal women. In tibolone can again be used, to treat menopausal symptoms. In case there is vaginal dryness and irritation, you can always use vaginal DHEA, dehydroepiandrosterone. And then bupropion in a dose of 50 milligrams up to 400 milligrams can serve the purpose. Buspirone, sildenafil are other drugs that can be used. Now coming to the management of female orgasmic disorder, here again a long list of pharmacological treatments that you can try. Again, sildenafil, bupropion, alprostadil, vaginal creams, nutraceuticals also like L-arginine, yohimbine, maca, flibanserin, amphetamines, and here specifically for inducing orgasm, mechanical device or mechanical vibrators are something that are commonly used. That is clitoral vacuum engorgement devices, which results into blood flow to the clitoris. It increases. So eros therapy, what is called eros therapy, that is FDA approved basically. And then there are several others, like for example, to mention a few, slightest touch, sacral nerve stimulation system, Fiera, which is nothing but wearable hand-free device itself. Okay, and there are certain techniques for to have good sex, to get good orgasm. That is coital alignment technique, wherein the partner is in a supine position and the woman is over the top of man. So this technique basically can help to increase orgasm in a female. There are some self-help guides and bibliotherapy, and Kegel's exercise, of course, plays very, very important role. Then coming to management of genitopelvic pain disorder, here because pain is the presenting manifestation, so something to reduce pain, like for example, local application of lidocaine or capsaicin, then steroids and interferons, hormonal therapy. Botulinum toxin has been, shown promising results actually with the type A type of botulinum. It is known to actually, cause inhibition of acetylcholine actually at the neuromuscular junction and help in muscle relaxation, as well as it also increases the increased blood flow, and it enhances the it actually blocks the nociceptors which are actually present in and around the clitoris and your pelvic floor muscles. So in that way it actually helps the client to overcome this pain. So of late, this has become a trend actually, botulinum toxin. And then tricyclic antidepressants, most of the times prothioridine and or that is doxycycline is used, and amitriptyline also can be used in low doses. Anticonvulsants like pregabalin and gabapentin has been tried. Psychological, therapies like I told you, cognitive behavior therapy or just behavior therapy, mindfulness technique, hypnosis can serve the purpose. Along with that, physical therapies like pelvic muscle floor exercise, myofascial release. If there is any kind of difficulty with the muscle spasm itself, that trigger point release. All these things are done by the physiotherapist basically. And this is one more, like when I talk about consultation liaison, even physiotherapists play a quite a significant role in helping out our clients, those who manifest with GPPPD, the joint and nerve mobilization, vestibular desensitization, and various type of vaginal dilators, as you know. Then novel treatments still given a trial are testosterone, bremelanotide, and alprostadil and other drugs. Then non-pharmacological management wise, again there is an overlap of the same. So what we need to know is here what I have highlighted. Psychotherapy plays a very very significant role. Once you know that there is psychological component which has played a significant role, we talk about sensate focus that is basically done under four stages. First is non-genital stimulation, and they take turns, the partners take turns, and they should only touch those areas which are non-genital. That is in stage one. In stage two, that is genital, they touch each other's genitals, taking turns. And third is again mutual. And last stage is nothing but intercourse, and they can have full orgasm. So this is what is about sensate focus, and they can continue to use this, a lady who is comfortable having masturbation can always use this Eros device that can help her to, achieve orgasm as well as arousal as well. And then you have to engage these couple for the couple therapy, resolve the conflicts between the couple, teach them, about, emotional therapy is also picking up these days, along with, systematic desensitization and mindfulness and yoga. And most importantly, that most of us forget is, lifestyle modification, wherein they need to look into their lifestyle habits, their sleep related habits, the diet that they consume, check on their weight, and the screen time, then the partner time. There are so many things, the exercise, everything becomes very very important. And how much mindful they are about the time that they are utilizing with each other. It is more, it is always important to have qualitative interaction rather than quantitative. So how much amount of time you spend is really not important, but what quality of time you spend with partners becomes very very important when it comes to sexual dysfunction. Then last few of my slides. So vibrators that I was talking about, this can be advised to the clients actually. Here, this is nothing but an Eros device, as I told you. This helps, this it helps the clitoris, the blood flow basically by stimulating the flow to the clitoris, and results into full arousal for sexual activity. And this is an external device that can be applied directly. Okay, and it is quite adjustable, and this is vacuum operated again. So there are, there is either a steady or pulsating vacuum that is already generated at different sensations. And this is FDA approved in the year 2000. The cost of this machine also varies from few thousands to many thousands. Okay. And there are well, I would like to just touch upon this digital and AI based treatment modalities. Of late, what we see is most of the times when adolescents, teenagers, or newly married, also for that matter, when they walk up to your clinic, they are into more of these apps, so called sexting, sexting apps, wherein they are discussing more about sexual intimacy related messages. They are forwarding some some videos with each other, and they are getting stimulated. So there are certain AI based treatment modalities also for people who are not willing to actually come up to you and seek for help. For example, there are mobile apps for sexual health and therapies. Some of them which I came across are Rosie, Furly, Enjoy, Mjoyo, V's O School, and so on. And there's something called as AI powered virtual therapist. So no more actually, in the current era, a therapist might soon be replaced by AI powered virtual therapists and chatbots. To name a few again, WeBot is a CBT based emotional support. Replica is again a non-judgmental emotional conversation that basically it holds with the client. And there are some custom built chatbots also, wherein clinician they are in concurrence with the clinician, and these AI bots actually help to assess as well as monitor this female sexual dysfunction. So there is something called as virtual reality and augmented reality, then AI assisted sexual cognitive behavioral therapy platforms also, and biofeedback and pelvic floor apps. So yeah. Then I conclude my presentation with this slide. D is something you have to define the dysfunction of the client when they walk up to, evaluate the underlying comorbidities, whether it is medical, surgical, gynecological, or any other organic condition, or a psychiatric illness itself. Screen using the tools that you already have in hand. They are simple to use. Initiate the treatment as you get to know whether it is primary or secondary sexual dysfunction. Refer whenever you are in doubt or you have two thoughts in mind. Make a consultation liaison with the team and educate and engage the clients for better compliance. So this is one slide that I found interesting. Love was never lost. It just needed a gentle reboot. So thank you one and all for your patient listening. Over to you, ma'am.
Uh, just a minute. Yes, now, ma'am, very nice presentation. I request all the participants, you can either put your questions in the chat box, or you can also unmute yourself and ask directly. We have some questions. We still have 21 participants. So, okay. So, shall we conclude, ma'am? Even I guess Ritamra ma'am is not here.
Excuse me, ma'am.
Yeah.
Yeah, tell me.
Hi, ma'am. How are
Hello.
you? This was a
Oh,
wonderful
I'm doing
talk.
well.
Thank you so much.
Yeah, thank you, Neha.
Ma'am, I had a question. Uh,
Yeah,
you mentioned a list of pharmacological agents that
yeah.
can be used. 1 second, ma'am. This was for. I'm so sorry. Uh, Ma'am, it included agents like fibanserine and bremelanotide. So I just wanted to know what is your personal experience of having used any of these drugs with patients?
Yeah, to be honest, it is not easily available in India.
Right, right.
Yeah, we tried our best to actually procure it from a few pharmas, although it is mentioned, it is quite difficult
Huh.
for the client to get these medications. But I have had experience of treating a few of my clients who are based in US, who have been from here. They have
Okay.
reported a quite good experience, I must say. After having used the molecule for about 3 to 4 weeks, as I said, and
Huh.
I saw them in the age group of around 35 to 40 and not beyond that. So I really don't have, say on patients who are in postmenopausal age group or perimenopausal age group per se. But it is
Okay.
definitely FDA approved, and I think soon it should be available over here also.
Okay. All right, ma'am. Thank you so much.
Mm. Do we have any other questions? So I guess it's 9-7. Ma'am, please, Ritama ma'am, please unmute yourself. I
Oh,
guess. Yeah,
sorry.
yeah,
If
yeah.
you can highlight some cultural differences or rural-urban differences in presentations, or even the approaches, or even sharing of these disorders. So, how do you see these things?
Yeah, that's a good question, ma'am. Thank you. Actually, I have had the personal experience of dealing with rural women because the dissertation that I was given then way back in 2009 was psychotropic induced sexual dysfunction. So let me be very frank. In the very first go, I myself was not very comfortable asking them these questions since I was not married during that time, and taking sexual history itself was a big taboo and quite challenging. So at one point in time I also felt that perhaps I may not be able to conduct this dissertation at all. But over a period of time after I started my dissertation, and my teachers and everybody helped me, guided me, then what I sensed was it was not really easy to actually talk about sexual dysfunctions from a woman who comes from a rural setup, basically, because most of the times they really did not understand every other domain of sexual functioning that I was actually asking. Maybe the number of times they do, or the pleasure aspect, or how it has declined. Those were the things which they were able to tell, but very conclusive of very specific to the point answers was not really narrated by them, and many of them even turned back saying that I don't want to discuss about this sexual problems with you, and I don't really need any treatment per se. And some of the times I even came across people who even said it is okay to have these problems. I am okay with this problem, and I really don't need discussion in front of anybody. So I think these were some of the things, and more so people who those who came from rural area, most of the times they came from joint family system, ma'am, wherein privacy issue was a big problem between the couple as well. And so there also, they lacked physical intimacy because of the reason that they did not have personal space with each other, and they did not have a separate room to share. Then when children were growing up, then it became difficult for the couple as well. So these were few of the things that I actually came across, and like I mentioned about some of the myths associated with female sex. So those were quite prevalent in the study that even I did.
Mm, thank you. Thank you for sharing, madam. Any more questions?
I guess we don't have, ma'am.
And I mean, when your patients are from higher socioeconomic strata, Veda,
Yes, ma'am.
you see them more expressive, or they are the same as like other
Ma'am, I think
women?
especially in Bangalore, they're quite open about their problems, ma'am. This is the latest trend that I am actually seeing, and just not about the sexual difficulties that they face, but also about their gender identity related issues or multiple partners. They just want to open up, and they wish to seek for help, is what I understand, ma'am. So they are more open. It is quite easy to communicate with clients from a metro background I would say, rather than for them, it has no more remained a taboo. I would say people open up, and even if they do not open up in the first place, at least when explained that this is what you are going through, then we definitely see quite a bit of women coming back for the follow-ups and trying to open up with the consultants actually.
And before coming to you, how often or how common is the practice that they have approached some other quacks or some other means of dealing with their problems?
Definitely, ma'am. This is a very good point you have raised actually. When it comes to male sexual dysfunction, I have come across this with respect to Dhat syndromes and even otherwise for premature ejaculation and EDs per se. But specifically for female sexual dysfunction, as such, people going to quacks, I did not come across much, but people would have definitely seek help of a psychologist, like I said, general physician, or somebody from Ayush domain, or gynecologist per se. So we get lot of consultation liaison cases. Much we may be the last person in line to actually treat them. Much before us, every other person would have evaluated them thoroughly. They would have given up on it, and we are the last people to intervene. So
Mhm.
that is my
Right.
experience.
Yes,
Mhm.
yes.
Any others in the audience who would like to share their experience? I see some Swati, Dr. Swati.
No, ma'am. No questions.
Ma'am, I have seen and treated 3 patients till now for vaginismus, and but probably through extensive CBT and behavior therapy, and yeah, maybe antidepressant for few of them, those who had dissociative symptoms. But yes, they did conceived, they thanked, so that did help. But again, many had borderline issues, borderline personality issues, so there were many other interpersonal difficulties also, which were actually increasing stress for creating a sexually secure environment also for from husband's perspective also. But yes, detailed CBT, it did help. They were very much open for treatment. They sustained for the treatment part for more than 1.5 years, and then gradually the first sexual encounter did happen successfully, and see, so gradually they conceived also and everything. So yeah, that part is still I've seen. So
I
then
have a word to say. So
yeah.
many a times, actually, we come across, young couple manifesting with, the features of infertility, and somebody would have
Infertility.
actually labeled them that, infertility is there, and you have to go for IVF or IUI and things like that.
Mhm.
But when we actually evaluate, if at all they are lucky enough to have walked to us, and if we just probe and if we try to find out, there could have been lot of religious, cultural taboos, myths, and sometimes not even aware of the anatomical regions, what actually plays a role. So, there could be a number of reasons existing between the partners itself and for not engaging themselves in sex, and perhaps this, overdiagnosed to be called as, infertile, or not being able to conceive, and so many times this has got reverted as well, I would say, by our interventions many a times.
Yes, many times. So then I guess, ma'am, we need to have better liaison with gynecologists, although they do refer whenever required. But yeah, that communication might build
Definitely,
the
it is a consultation liaison branch, and I think everyone plays a significant role here.
true, ma'am, true. So I guess,
Yes.
do
Thank
we
you,
have any
ma'am.
other questions? I think nobody has, ma'am.
Great. It was very informative, Dr. Veda.
Yes.
Thank you.
Ma'am.
Thank you. Ila, you can wind up.
Yeah. Yes, ma'am. So very informative session, ma'am. Thank you.